Our next speaker is Dr. Abhishek Vaidya. He's a surgical oncologist at National Cancer Institute, Nagpur.
Thank you so much. This is turning out to be a delectable affair. Krupa Shankar and Sameer have served you the entree and the main course. I'll give you the dessert though. So here we go. Oi. Dessert coming up. Just a little wait there. So I'm going to skip the prologue. We know that T3N0 is what we are talking about, and the critical issue here is the function. I think this is the most controversial issue in head neck right now. How do we treat these? So until the mid 1990s, for laryngeal cancer, surgeon was the absolute unabated king. And then these two trials happened, and the surgeons were left twiddling their thumbs. And my radiation and medical oncologist friend would like to have me that way, but no. I think surgery is a devil which you know better than the angel you don't. There is much more that which hasn't met the eye with radiation and with medical oncology. So here we go. What do I plead in this debate? I say that there are several shortcomings in the laryngeal preservation trials and we need to re-examine them. The survival with laryngeal strategies is not as good as with surgery. Larynx is preserved, but does it retain the function? T3 is a heterogeneous group, so laryngeal preservation may not be applicable in all. Quality of life with LP, are we sweeping a number of things under the carpet? And there are effective, well-proven conservative surgery available. Are we neglecting them? So let's tackle them one by one. Let's first see the shortcomings. So both of these trials had several shortcomings. First of them was selection bias. If you look, the accrual took place very painfully over a very long time, which meant they were selecting too many patients. I mean, they were putting too much in the selection. A lot of these patients had vocal cord mobility. So really they were not the candidates for TL, right? So why are we comparing them against TL, especially the VA trial? The definition of advanced disease was skewed. Sameer said that a lot of bulky diseases were included, as also a lot of early diseases. So what were you comparing exactly? And finally, there was no comparison with laryngeal conservation surgery at all. That's not it. Most of the patients had excellent performance status. That explains why they accrued so slowly. In community, this may not be feasible. Very high toxicity and treatment deaths in the range of 5%, right? So we now move on to the next point, and this is the crux of my debate. I think that the survival with laryngeal preservation strategies is worse. There is more than what meets the eye, and here goes. I'm thankful to Dr. De Cruz for this slide. First of all, both of these trials, they did not have good endpoints. They were not powered adequately to answer a few questions. If you look at the VA trial, there was no mention of the sample size. Survival was reported only 2 years. If you look at RTOG 9111 trial, they changed their initial endpoint to a composite, more easily attainable, doable, endpoint. And if a trial has to be done well, it'll need several events and close to 1,200 patients. Did LP actually worsen survival? And this is an important paper. This is a meta-analysis of 3 IPDs. So, which showed that the hazard ratio showed a trend in favor of the surgery group when it was compared to induction followed by radiation. And there was an absolute detriment effect to the tune of 6% with induction followed by radiation. Now, mind you, these were the, induction followed by radiation was the only one which was directly compared to surgery. So, I can only talk about this. And this is again that forest plot showing that there was a detriment, and this detriment is enough for us not to replace surgery as a prime modality of management for these cancers. There are further doubts about the safety of the LP strategy. Hoffman et al. And Chen et al. Later, these papers have come forth. They used the NCDB the database, and they showed that over the community, due to declining use of surgery and increasing use of chemoradiation, survivals due to laryngeal cancers, particularly those of T3 laryngeal cancers, had fallen down. This was the Hoffman paper, and this is the Chen and Halpern paper. We move on to the next point. Larynx is preserved, but does it actually retain its function? And what happens to quality of life? Several issues swept under the carpet. Let me reiterate, preserved larynx is not equal to preserved laryngeal function, and it is not equal to good quality of life in all. Now, this is a very important paper, very elegant paper. RTOG brought this out. It analyzed long-term toxicity in 3 of its trials where concurrent chemoradiation was given, and look at the incidence of pharyngeal dysfunction, laryngeal dysfunction, and feeding tube dependence. Very high. 1/3 and a fifth and a fifth. And if you look at which of the patients had this. These were the laryngeal and the hypopharyngeal patients. So LP not without disadvantages, laryngeal edema, stenosis, tube dependence, aspiration, to name a few. Salvage surgery will be required in a third of these patients. It will be difficult. And salvage, when required, will be total laryngectomy in most of these patients. Once again, on to dysphagia and aspiration, I won't go into details, but up to a third of patients will have permanent dysphagia, will have permanent tube feeding. Aspiration is common, especially silent aspiration. Look at the paper I've quoted at the bottom. From MD Anderson, they found when they did a modified barium swallow, 84% of these patients aspirated. Half of them were silent aspirations. So that's a big concern there. Further is the issue with salvage surgery. In RTOG 9111, half of the salvage surgery had major complications, including pharyngocutaneous fistula. Not only that, the evaluation of patients is going to be very difficult. You will only need a PET CT scan. Your biopsies may even be negative. Now, let's move on to another point which I want to make. T3 is not one group. T3 is an extremely heterogeneous group. And this all constitute T3. Pre-epiglottic space involvement, paraglottic space involvement, erosion of the inner cortex, extension to the postcricoid. I loved your igloo slide, by the way, but one size really does not fit all. And laryngeal preservation trials, they actually considered stage grouping rather than T3. And that is what I said. A lot of these patients had mobile cords. And this is reflected in the results. If you look at the long-term outcomes with salvage total laryngectomy of the RTOG 9111 group, those who had fixed cord were more likely to undergo a salvage laryngectomy. Now, this just about reached significance, but it's important. On the other hand, surgeons have understood the intricate anatomy, and they have devised specific organ preservation strategies for subparts or subunits within this subsite. Not only that, they have identified subgroups which will be benefited best with the conservation strategy. Long story short, the ones in the red are ones which will not benefit laryngeal conservation strategy. Further, laryngeal preservation strategy may not be uniformly applicable because of good performance status in the trials which cannot be replicated in the real world. Rigorous follow-up which was required, which may once again not be replicated in the real world. Supportive care, much more is required. I really don't want to play the India as a developing nation card. We have enough linear accelerators, but still access may be an issue. Finally, effective surgical organ preservation options are available. I'm not going to go into detail with them because there are several lectures about them, but enough data to show that there are very good, effective, safe laryngeal preservation surgeries available. And when you compare them with RTOG 9111 on the left-hand side, it matches and overdoes RTOG 9111 in every single thing. So let's compare CT-RT versus conservative surgery. Duration of treatment is less, average duration of recovery is less, lesser supportive care is required, lesser need for multi-faculty care, and lesser need for adjuvant RT as well. Word of caution as mandatory that this has to be done in very selected patients. Finally, just a hobby horse. Is it a lost art? My mentor is sitting in the audience. I'm keeping him incognito. His mentor used to do conservation surgeries very, very frequently. My mentor does it frequently, me rarely, and I call him 10 times every time I do him. My fellows will probably never do it. This is a portrait by Raphael which was lost in the World War II. Do we want this to happen to our surgeons? There are newer avenues which beckon us, induction followed by surgery, transoral robotic surgery which will decrease the morbidity. So to conclude, T3 laryngeal cancer is a heterogeneous group with anatomic intricacies. Treatment options should be discussed in detail on a tumor board. They should be carried out as per the patient status, disease status, and local expertise. Preservation strategies came in with a bang, I agree, but they have many shortcomings and long-term issues. Surgery remains the gold standard, and no LP protocol has equaled its safety. Conservative laryngeal surgeries in selected patients give excellent outcomes, and robotic surgeries will only further decrease the morbidity. Thank you so much.